module, and it will address the question, what is meant by the term receptor selectivity? At the end of this presentation, you should be able to explain what is meant by the term receptor selectivity, explain how drugs can be shown to be selective in their effects on individual tissues and receptors, and explain the importance of the receptor selectivity of agonists and antagonists in clinical practice. Drugs have been used by pharmacologists for many years as a useful tool for exploring human physiology. For example, some structurally related agonists such as the catecholamines, adrenaline and noradrenaline, were found to have effects of differing magnitude in organs such as the heart, lungs and blood vessels. This led to the identification of different subtypes of adrenoceptor. Not only did the receptor subtypes differ in their response to these agonists, they also differed in their susceptibility to competitive adrenoceptor antagonists. These findings led to the concept of selectivity, where a ligand can bind with higher affinity to some receptors of a specific type compared to others. Selectivity is now widely exploited in modern therapeutics to produce drugs that have beneficial effects by selectively activating one receptor subtype while avoiding activation of others that might lead to adverse effects. Receptors are named on the basis of their primary endogenous agonist, for instance adrenergic, serotoninergic or opioid. They are then usually subtyped on the basis of their selectivity for agonists or antagonists. The first receptors to be explored in this way were those responding to the catecholamines adrenaline and noradrenaline, which were consequently known as adrenoceptors. It quickly became apparent that not all adrenoceptors were the same. Although they all responded to adrenaline, only a proportion were responsive to the synthetic catecholamine isoprenaline. This led to the subclassification of adrenoceptors into alpha and beta. Further experiments determined that beta receptors themselves could be subtyped into those which were highly responsive to noradrenaline as well as adrenaline, known as beta-1 adrenoceptors, and those that were poorly responsive to noradrenaline, known as beta-2. Alpha receptors were subtyped in a similar way. These receptors were found in varying abundance in different organs, allowing those organs to respond differently to circulating catecholamines. For instance, alpha-1 adrenoceptors are found in blood vessels where they respond to catecholamines by producing vasoconstriction. Beta-1 adrenoceptors are found in the heart where they respond to catecholamines by increasing the rate and force of cardiac contraction. Beta-2 adrenoceptors are found in both the lung and blood vessels where they respond to adrenaline to produce bronchodilatation and vasodilatation respectively. The differential responsiveness of receptor subtypes was originally identified by plotting dose-response curves for agonists acting on different tissue preparations. The agonist selectivity could then be quantified by measuring the ratio of the EC50 at the two different receptor subtypes. In this example, the dose-response curve for noradrenaline acting to increase heart rate and causing bronchodilation in the lung is plotted on the same curve. The noradrenaline dose required to cause bronchodilation is much higher than that required to cause tachycardia. The degree of agonist selectivity for noradrenaline at these two sites is quantified by comparing the ED50 of the two curves. The selectivity of noradrenaline for cardiac receptors with respect to lung receptors is 10. In other words, the noradrenaline dose required to cause 50% maximal bronchodilation is 10 times greater than that required to produce 50% maximal increase in heart rate. It was on the basis of these initial observations that pharmacologists were able to subtype the adrenoceptors in the heart and lung into beta-1 and beta-2 respectively. We have observed how receptor subtypes can be identified by their differential response to agonists. Receptor subtypes can also be distinguished by the relative effectiveness of drugs that antagonize the effects of their agonist. Antagonist selectivity for two different receptor subtypes is measured as the relative shift of the agonist dose-response curves achieved by a single dose of the antagonist affecting responses mediated through each. For example, The non-selective beta-adrenoceptor agonist isoprenaline is equally effective at both beta-1 and beta-2 adrenoceptors and would have a similar dose-response curve for its effects on increasing heart rate and bronchodilation. Pre-treatment with a 50 mg dose of the competitive beta-adrenoceptor antagonist atenolol causes a shift in the isoprenaline dose-response curve to the right for both bronchodilation, a beta-2 mediated effect, and increased heart rate, a beta-1 mediated effect. However, comparison of these curves constructed after a single dose of atenolol indicates that 10 times as much isoprenaline is required to overcome the effect of atenolol in the heart than in the lung. Therefore, the selectivity of atenolol for beta-1 adrenoceptors over beta-2 adrenoceptors is 10. For that reason, atenolol is often called a beta-1 selective or cardioselective beta blocker. It is important for prescribers to remember that selectivity for a receptor subtype is only relative. Selectivity does not equate with specificity. Agonist or antagonist drugs that are considered to be selective for one receptor subtype can still produce significant effects at other subtypes if a large enough dose is given. This is particularly important if the beneficial effects are activated by one receptor subtype and the unwanted effects by another. Atenolol is considered to be a beta-1 selective adrenoceptor antagonist that antagonizes the effect of adrenaline and noradrenaline at the heart. This property is very valuable for patients with angina pectoris because it reduces the work of the heart. Its selectivity means that it is less likely than non-selective beta receptor antagonists to cause adverse effects at beta-2 adrenoceptors, including those at the lung which mediate dilatation of the bronchial tree. However, asthmatic patients have a tendency to severe bronchoconstriction during attacks, and an important protection against this is the beta-2 mediated bronchodilating effect of the endogenous agonist adrenaline. Atenolol can interfere with this mechanism and will also antagonize the effect of exogenous adrenergic bronchodilators such as salbutamol taken via an inhaler. For this reason, atenolol, like other beta-adrenoceptor antagonists, is absolutely contraindicated in asthmatic patients, even though it has a degree of selectivity for cardiac beta-1 adrenoceptors. Selectivity is useful in clinical practice only when the ratio of the impact of the drug at the two receptor types is 100 or more. When the ratio is lower than this, it is difficult to predict the drug doses for individual patients that will exploit the differences in subtype activity. Selectivity is most likely to be achieved at the lowest effective dose. Higher doses will not increase efficacy and will begin to have adverse effects at other receptor sites. That brings me to a brief review of the key points of this presentation. Selectivity of agonists and antagonists for receptors enables those receptors to be classified and subtyped. Agonist selectivity for two subtypes of a receptor is the ratio of the ED50 from the dose-response curves plotted for the responses mediated via the respective subtypes. Antagonist selectivity is the ratio between the ED50 change seen when the full agonist dose-response curve is plotted in the presence and absence of the antagonist for responses mediated via each receptor subtype. Selectivity of agonists and antagonist drugs at receptor subtypes is a relative phenomenon, meaning that it may be lost when the dose of the drug is increased. You can find further reading and resources to support your learning at the locations shown. I hope you found this presentation helpful and look forward to you joining me again for more clinical pharmacology at this site shortly.